Good morning, everyone. Today I'll be presenting an article on intraoperative transit time flow measurement and high frequency ultrasound assessment in coronary artery bypass grafting. That is a request study, that is Registry for Quality Assessment study by David P. Teckhart. We'll be covering this topic in subheadings including the introduction, methods of intraoperative graft assessment, methods of data collection, results, discussion, future perspective, limitation, conclusion, and NH experience. As introductory part, intraoperative graft failure is well documented. Around 4 to 5% of the grafts and 10% of the patients who are asymptomatic in the operating room, which are showing no changes in the hemodynamics or ECG, may present with the graft failure. The quality assessment in the CABG has formal guideline recommendations, including the TTFM graft flow assessment in 2010, 14, and 18 ESC guidelines with evidence level 2A and B. Epi-aortic ultrasound scanning in 2011 by American College of Cardiology as second AB evidence. And the adoption of the TTFM and CABGs varies geographically, being Japan being more than 90%, the Germany and Scandinavia being 70 to 80%, and the US being 25%. The high frequency ultrasound in addition to the TTFM shows promising result. So the aim of request study is the prospective multicenter registry study to assess the potential value of combining the TTFM and HFUS in CABG. The abstract of the study, including the objectives to evaluate the influence of the TTFM with epicardial and epi-aortic high-frequency ultrasound in patients undergoing CABG. The methods includes the multi-center prospective study, which was done among 7 international centers performing CABG grafting procedures. The primary endpoint was any change in the planned surgical procedure, and the major secondary endpoints consisted of the rate and reason of surgical changes, which may be related to the aorta, the conduits, the targets, and the completed anastomosis. And the last is the in-hospital mortality and the major morbidity because of the graft dysfunction. The results between the April 2015 and 2017 were done. Around 1,046 patients were enrolled in the study, and out of this, only 1,016 were included in the final analysis. The mean age was 65.9 years, 14% were women, and diabetes was present in 39.6% of the cases. Off-pump CABG was performed in 39% of the cases with the harvesting of the bilateral ITA, internal thoracic artery, in 30% of the cases. Since the introduction of the CABG more than 5 decades ago, surgeons have consistently focused on reducing the perioperative adverse events and improving the graft patency. Additional measures to improve the long-term outcomes through superior conduit selection, that is including more of the arterial grafts, implementation of the less invasive techniques, that is minimally invasive techniques, and secondary preventive measures are constantly advocated. Although overall outcomes have significantly improved over time, the endpoints of mortality, stroke, and the graft patency remains key targets for further optimization. Various intraoperative techniques continue to be recommended in terms of the intraoperative quality assessment, which includes the transit time flow measurement and identification of the disease-free aorta using the epi-aortic high-frequency ultrasound imaging to allow safe manipulation and thereby reducing the chances of a stroke. TTFM itself assesses the graft flow by inference, the quality of anastomosis and/or conduit, and allows immediate graft revision in situation where the surgical results are not optimal. And the same HFS is used for epi-aortic scanning to identify the diseased aorta before any aortic manipulation. Epicardial coronary artery scanning to identify the potential target vessel anastomosis sites that are free of plaque, especially on the posterior wall. Ultrasound of the conduits when dissection is suspected, and post-anastomosis scanning to identify potential anastomotic characteristics that limits the graft flow. So the combining these two techniques can help in reduction of the perioperative adverse events and improves the graft patency. The 2018 European Society of Cardiology and European Association of the Cardiothoracic Surgery guidelines on myocardial revascularization provided a secondary recommendation and evidence level B for intraoperative graft flow assessment and evidence level C for epi-aortic scanning during CABG. Consequently, the Registry for Quality Assessment study aims to determine the number and the type of surgical changes that are made on the basis of the results by the TTFM and HFUS. Now, in methods of intraoperative graft patency assessment. Conventionally, the quality and the flow of graft were checked with naked eyes before anastomosis, as well feeling the flow in the graft with the digital palpation, checking the patient's hemodynamic condition, new ECG changes for ischemia, and new heart wall motion abnormalities with transesophageal echocardiography after anastomosis. Unfortunately, it is hard to detect graft failure by visual checking, classical monitoring, and palpating the graft. A graft dysfunction can occur without hemodynamic ECG or echocardiographic changes. There are some advanced techniques to detect the occlusion and severe stenosis of the graft or anastomosis, even in the absence of hemodynamic changes. The best to determine for a surgeon is during the surgery. So, TTFM and HFUS gives the opportunity to revise the grafts, which in turn helps the surgeon's frustration as well as improves the patient outcome. So, graft failure is a troublesome event that can lead to severe complication, including the myocardial ischemia, refractory angina, arrhythmias, low cardiac outputs, and fatal cardiac failure. Even though coronary angiography is the gold standard and most reliable method for intraoperative graft patency, when considering the cost, availability, additional surgery time, and the risk, it may not be very practical and feasible way of assessing the graft patency. Assessing the patency of the graft through transit time flow measurement and ultrasound is non-invasive, simple, reliable method of flow measurement of the graft while the patient is still in the operating room. So TTM-FM was first used for the quality control in CABG in 1998 by Velpert et al. Sir?
Go on, please go.
Yes. Yes, sir. And has been constantly its use since then. The 2018 ESC and EACTS guidelines on myocardial revascularization also recommend the use of TTFM. In TTFM, the main three parameters include the mean graft flow, the pulsatility index, and the diastolic filling and the backward flow. The revision is recommended if the two of the above three criteria are not met. What is a transit time flow measurement? Transit time flow measurement is based on an ultrasound technology, and the graft must be placed perpendicular to the U-shaped housing that contains two ultrasonic transducer and a fixed acoustic reflector. During minimally invasive or robotic CABGs, TTFM probes without a handle may facilitate the TTFM readings. Ultrasound beams are transmitted from the transducer through the reflector in both the upstream and the downstream direction of the blood flow. The blood volume flow is then derived from the difference in the propagation time, transit time of the upstream and the downstream beams, and gives an accurate identification of the real-time flow. The key variables includes the four: the mean graft flow, the pulsatility index, the percentage of the backward flow, and the diastolic filling. The mean graft flow value is expressed in milliliters per minute and is generally reported in the left up corner of the screen. In addition, it is displayed on the horizontal red line across the flow curve. The flow curve has a systolic pink and a diastolic blue component, and the mean graft flow is influenced by several factors, including the size and the quality of the conduit and of the target vessel, the turnover in the distal coronary vascular bed, hemodynamics, competitive flow, and the quality of anastomosis. The mean graft flow should be around 15 to 20. If it is less than that, then the revision of the graft is recommended. Pulsatility index is calculated by dividing the difference between the peak flow and the minimum flow by the mean graft flow calculated across a 5 cardiac cycle and is expressed in as absolute value. So the PI is most important among the four. The PI represents an estimate of the flow resistance and is an indicator of flow pattern. The PI is influenced by all types of the resistance to the flow, including the graft stenosis, the distal native coronary artery stenosis, the competitive flow, and the anastomotic quality. Third, the percentage of the backward flow represents the portion of the flow directed backward into the graft across the anastomosis during one cardiac cycle. It generally indicates flow competition between the native coronary artery, and it is displayed as the area below zero on the flow curve. The fourth is the diastolic filling, which expresses the proportion of the diastolic graft flow. A diastolic flow pattern is the predominant in all graft and is more pronounced in the left coronary artery system as compared with the right because of the higher transmyocardial pressure gradient. The diastolic filling varies with the site of measurement and is higher in the distal portion of the graft. For assessment of the graft function, one should consider and integrate all described variables rather than relying on one of them. So, with increasing TTFM experience, surgeons are likely to become better at evaluating their approach to abnormal TTFM measurements. Although fibrotic diffuse disease target vessel may reveal a poor TTFM parameters, it is important to consider any discrepancy between the observed and the anticipated flow as a strong indication to revise a graft. Because inapparent issues such as endemal flap, obstruction by clots, fat particles, internally tangled sutures, or other caveats may occur despite correcting graft position and meticulous anastomotic construction. So there are circumstances in which the anastomosis may appear normal because of the high flows into the functioning part of the anastomosis, especially when the target coronary artery has a large area of distribution. This problem can be identified by remeasuring flows after atraumatic proximal snaring. So this is a diagram which is depicting how to put a probe to get a proper estimation of the graft flow. So the vessel should be placed perpendicular to the U-shaped probe to get an accurate estimation. The graph which is showing the systolic pink component and the diastolic blue component with a PI of 1.7 and the mean flows of 79. The other diagram which is depicting the downward bending of the vessel can lead to the underestimation and increased PI, while the upward bending of the vessel can lead to the overestimation with good PI. This is another diagram which is depicting a normal CABG saphenous vein graft to the circumflex artery, showing the blue component that is null, that is the diastolic component, the PI of only 1.5 and the mean grafts of flow of 50 ml per minute. And the downward and the backward flow is also less, depicting the less competitive flow in the target vessel. This is another diagram which is depicting where to measure the graft from proximal mid to the distal part. So as we go from proximal mid to the distal, the PI is improving from 2.2 to 1.4. So always the TTFM probe should be placed as near to the distal anastomosis site. This is a flow chart which is depicting when to intervene in case if mean graft flow of more than 15 and a PI of less than 3, then record the time before the closure TTFM and that is normal. If it is not, then consider MAP of more than 70 and then measure. If MAP is less than 70 and we repeat it at a MAP of more than 80 and the graft flows are still less than 15 and a PI of more than 3, then functional tests are measured and the evidence of the competitive flow is, and then the considering of the revising the graft is assured. This is one more diagram which is depicting the false negative measurement of the TTFM. This is most likely to occur in the CABG when the myocardial is supplied both antegrade and the retrograde to the anastomosis with the perforators. Now the second is high frequency ultrasound epicardial echocardiography, was developed for the assessment of the morphological and the functional information of the graft and anastomosis quality. Several clinical reports.
Move the slide, please.
Yes, sir. Is it visible, sir?
Yeah.
Okay. Several clinical reports have established its efficacy intraoperatively.
Back to the previous slide, the diagram.
Yes, sir. Is it visible, sir?
Yeah.
Yeah, thanks.
High frequency epicardial echocardiography was developed for the assessment of morphological and functional information of the graft and anastomosis quality. Several clinical reports have established its efficacy intraoperatively. Anastomosis assessment is performed by using a high-frequency linear probe with a frequency ranging from 10 to 13 MHz. A study of used HAE and power Doppler imaging for the assessment of the coronary arteries and the graft anastomosis during CABG. The maximal luminal diameter of the graft at the site of the anastomosis was obtained intraoperatively by using a power Doppler imaging and was compared with a postoperative coronary angiogram. Excellent correlation was observed between these modalities, and they concluded that the patency of anastomosed graft could quickly be evaluated by epicardial echocardiography. Similarly, a study by Bud et al. Evaluated 3 different types of the intentionally created coronary anastomosis construction errors, being the suture crossovers, the purse string, and the deep toe stitch, by using the HE with a linear probe of 13 MHz frequency. HE enabled the detection of the construction errors with high sensitivity and specificity. On the contrary, Hall et al. Conducted another study when they compared the measurement of the graft diameters and the graft quality assessment using the epicardial ultrasonography with those measured using the intraoperative angio. They found poor correlation between the two methods of the graft diameter. However, epicardial ultrasonography detected 13% of the abnormal grafts, with the invasive coronary angiography found 23% of the abnormal grafts. Now, coming to the request study, the study overview objective was to register the number and the type of CABG surgical procedure changes. Its design includes the multi-center prospective study of 1,000 patients. The governance by ethical approval published in Clinical Trials in February 2015. Isolated CABG patients were included in the patient population, at least a two-vessel disease, and the enrollment period was from April 2015 to December 2017. Overall, 1,046 patients were enrolled and 30 patients were being excluded from the study due to ineligible regions. Coming to the study design, the request study is an international multi-center prospective registry that enrolled these many patients in 7 centers routinely performing CABG in the Europe and North America between April 2015 to 2017 December. This registry was designed to capture information on any changes in the proposed surgical procedure based on TTFM and HFES parameters performed with the Miracu or Vericu devices. All patients enrolled in the request study signed written informed consent before the surgical procedure, and each participating site received approval from the Institutional Review Board or Ethics Committee before screening and enrollment of the all eligible patients. Study protocol. Participating surgeons and the study coordinators at each site were trained how to use and interpret intraoperative TTFM and HFUS results according to the structured request study protocol. This protocol ensured that participating surgeons and the personnel were trained in the use of the intraoperative TTFM and HFUS and possessed good clinical practice certification. So all participating surgeons had previous experience with using this. It is strongly recommended, and the surgeons who has performed at least 20 cases with TTFM. The recommended surgical steps for quality assessment, including HFUS assessment of the ascending aorta to the presence or absence of any plaque, soft or hard, or vessel abnormalities, to establish the safe sites of the cannulation, cross-clamping, and side biting for the proximal anastomosis. HFUS assessment in the in situ conduits were also assessed. During intraoperative quality, a mean arterial pressure of 80 mmHg was recommended, and HFUS probe frequency was set at 15 MHz. Furthermore, the request protocol advised to standardize and optimize TTFM assessment that the acoustic coupling index should be green or yellow, indicating the accuracy of the ultrasound conductivity. The mean graft flow should be steady horizontal with the pulsatility index should be 70% for the left-sided and more than 50% of the right-sided coronary vessel. It was at the discretion of the operating surgeon and if a graft failure should be revised. If the graft was revised, it was recommended to reassess the conduit flow with the TTFM post reconstructed anastomosis. Patients diagnosed with a multivessel disease were scheduled for isolated CABG, were included in this. Emergency CABGs, concomitant other procedures with the valve repair were not included in the surgery, and with any muscle disorder, myalgia, myopathy, all these patients were not included in the study. The study objective includes the 4 endpoints. Any change in the planned surgical procedure. Why was the type of the change, whether it was related to the aorta, the conduit harvesting, or coronary target, or the anastomosis itself. The number and the reasons for the anastomotic revisions, and the major adverse cardiovascular and the cerebral events during hospitalization. So 4-step protocol includes the first thing which was done in this study is the high frequency ultrasound scanning of the aorta prior to its manipulation, the accuracy of the conduits after harvesting and the coronary targets, the TTFM of the graft, which includes the flow, PI, diastolic filling, and the backward flow, and the HFUS of the anastomosis. Coming to the protocol adherence, the 99% of the surgeons use the TTFM, 79% use the HFUS for the aorta, and 65% for the conduit harvesting, the coronary target being 48%. Sir?
It has disappeared.
Sir?
Now it's come. Yeah, okay.
So 99%, so most of the surgeons were using the TTFM. In 99% of the cases, the HFUS was comparatively low as compared to the TTFM use. Adherence to the protocol was recommended but not mandatory. Surgeon experience, preference, and discretion was allowed. And learning curve for HFUS scanning, especially for the coronary targets and anastomosis, was quite high. Now, coming to the results of the request study, so changes to the overall planned surgical strategy. So, usually manual and visual changes was only detected in 13% of the cases, not defined in 10% of the cases, but 77% TTFM identified correctly when to change for the surgical strategy plan. And in that case, aorta was related around 9%, conduit in situ being 2%, the graft being 7%, and the coronary target being 22%. So changes in the planned aortic manipulation. So this is a diagram which is depicting the HFUS pre-existing aortic dissection flap and a soft plaque. So with that use, 93% of the cases, HFUS has identified correctly the aorta quality before any manipulation. In visual cases, it was only 5%. Changes related to in situ conduits, either using the HFUS and TTFM, it's identified in 56%. And this is a diagram which is depicting the lima with dissection with color flow mapping. Surgical strategies, which are changes in the coronary target. So TTFM identified 68% of the cases, while on visual assessment, it was only 9% of the cases. Surgical changes which are related to the graft, 65% of the cases TTFM have identified the surgical changes. The primary anastomotic revision was 4%. That is the revision of the proximal or distal due to primary technical problem in the anastomosis itself. Secondary anastomotic revision was in the revision of the proximal or distal as a consequence of needing to do a redo graft but not do the problem with the anastomosis. That was only in the 2.8% of the cases. This is a table which is depicting the changes with related to the grafts surgical scenario. Anastomotic revision, secondary anastomotic revision, primary conduit revision, and the additional grafts. So primary anastomotic revision, which was because of the problem with the anastomosis itself, it could be because of the twisted anastomosis, removal of a stitch, redo anastomosis due to leaking, plaquing, tapering, bulging, or a flap or narrowing, and changes from proximal anastomosis to the aorta by Y or T graft configuration. So the request study, the in-hospital outcomes, there are only 2% of the cases in which major adverse cerebral and cardiovascular events has happened. The overall mortality was only 0.6%, with the stroke being 1%, the MI being 0.3%, and repeat revascularization taking in as an emergency OT is only 0.1%. Baseline characteristics and the medical history for the request study include the diabetic age was around 66 plus minus 9 years. Most of the patients were male. BMI of 28 was kept. Diabetes was around 40%, the MI 33%, prior history of PCI and stroke 23 and 6% of the cases. And the characteristics includes the main stem disease were present in 35% of the cases and unstable angina in 31% of the cases. So this diagram is depicting the changes which were related, the use of the HFUS and the TTFM in relation to the in-hospital mortality. So this is a diagram with the use of a TTFM. Pre-protamine, there were good flows, low PI, good diastolic flow, no issues with the graft. But post-protamine, suddenly flows came down, PI has increased with good diastolic filling. So we did a HFUS and we found a intimal flap in that. And in this diagram, after revision of the graft, the TTFM was improved and an HFUS also widely open anastomosis was seen. So the request study is the first prospective multi-center study that assessed the effects of the routine use of the TTFM and HFUS according to pro-specified protocol in patients with multivessel coronary artery disease. As evidenced by the high proportion of the off-pump operation and the use of the multiple arterial graft, these procedures were performed by experienced surgeons among 7 well-established institutions. And overall surgical changes, initially proposed surgical strategy was made in 25% of the cases. The present study showed that the surgical changes related to the proposed site of the aortic manipulation was 9%, and the revision of the grafts were done in 7% of the cases. There were definitely low rates of the major adverse in hospital events, and in particular mortality, indicating the intraoperative quality assessment of the aorta, conduits, targets, and the completed grafts. Although intraoperative quality assessment of the aorta and the grafts are recommended on myocardial revascularization, then potential limitations of the TTFM, including uncertainty over its diagnostic accuracy, have been discussed. Furthermore, in the absence of the clinical follow-up data, no clear consensus on the routine applicability of TTFM alone has been reached. Indeed, numerous single-center retrospective studies reported on the impact of adopting this, but the results are substantial heterogeneity in definition and outcomes. So, although very high use of the TTFM and this was recommended, but still at present at present the use of the TTFM and HFU is not much. So although surgeons were advised to follow the request study protocol, it was not deemed mandatory, and the discrepancy in the actual HFUS use most likely reflects the real world clinical decision making during the CABG based on surgeons' experience, preference, and discretion. And a graft with excellent flow indicated by TTFM is most important. Additionally, patients with a surgical change related to the aorta were more often patients who underwent off-pump surgery compared with the on-pump surgery. The surgical changes in the aorta in the off-pump cohort were mainly related to determining the optimal site, disease-free, plaque-free site for the proximal anastomosis to diminish the detrimental effects of the aortic manipulation in patients with an increased atherosclerotic burden. And what were the limitations of the request study is that it's the largest prospective study to evaluate the influence of the routine use of TTFM, but its most obvious limitation, it was not a randomized trial and therefore did not compare CABG with versus without the use of the TTFM and HFUS. So the reality is that the design, such as the randomized control trial, would need more an extraordinarily large patient sample size and extensive long-term follow-up to assess the influence of the improved long-term graft patency. Furthermore, interpretation of such trial would be complicated by myriad of other factors that influence the short and long-term outcomes of the CABG. Effect of the revisions did they alter the outcomes positively, and highly experienced CABG surgeons, whether it will give better results in the less experienced.
Your slide is disappearing.
Now, sir?
Yeah, yeah.
So the limitations being it's not a randomized controlled trial, and we don't know whether it can be performed in a low volume, low experience CABG unit, and the effect of the revisions, whether they alter the outcomes positively in the long-term follow-up. The conclusion, request study is a multi-center prospective study to design, evaluate the effect of implementing intraoperative quality assessment by TTFM and HFUS in 1,016 patients undergoing CABG. The rates of in-hospital mortality and the major morbidity were low, showing the feasibility and the safety of performing intraoperative quality assessment. So to conclude, the intraoperative quality assessment improves the quality, safety, and efficacy of CABG procedures and should therefore be considered as a routine procedural aspect during CABG, combining it with the conventional techniques which we are using in the CABG. Coming to the NH experience, NH we are using regularly TTFM flow measurements for the intraoperative graft assessment, but there is no indication for the high frequency ultrasound imaging. So for assessing aorta, any plaque, or we can either go ahead with a transesophageal echocardiography in the OT itself, or before we are planning for an HRCT chest. So use of the TTFI has significantly reduced the in-hospital mortality, and most surgeons in NH prefers redoing anastomosis if the PI is more than 5 with a mean graft flow of less than 15 with a change in the graft pattern. If the graft is showing the competitive pattern, then most surgeons prefer to put a venous vein graft over the in case as compared to the limb.
Have finished?
Yes, sir.
Okay, thank you. And it's a good study of multi-center study, prospective but not randomized, from 7 centers, which are excellent and published in JTCVS. So, but the thing is, what exactly do you mean by transit time flow measurement? Actually, this is
So we
for the understanding of all the others.
Yes, sir. So we are using this technique, just ultrasound based technique, in which we are measuring the graft flow. So the most important among the four parameters was the pulsatility index, which measures the mean graft flow across the 5 cardiac cycles.
I'm I'm saying about the basic principles of this.
Yes,
Of
sir.
ATFR. Actually, it is something in the dynamic physics and rheology, where measurement of flow can be measured by ultrasound.
Yes.
The proximal one giving the impulse, and the distal one sensing the impulse, and the transit time. From that, you calculate the flow. That's all physics principles. In any tube through which fluid is moving, the transit time gives you an index of the flow. That is the basic principle. In
Yes.
this, when you use it in coronary artery surgery, it's very good. But I don't know how practical every case. is. Do you do routinely this in our
Yes,
hospital?
sir. Yes, sir. All routine cases we are doing, sir.
It's important because all the time we measure, we have no quantitative measurement of the patency of the graft. You decide on the filling of the graft and the pulsatility of the graft. But that's misleading, because even if your distal anastomosis, the distal part is stenosed by a suture is taken wrongly, or even the posterior wall, it will be
Yes, sir.
pulsatile because of the retrograde flow, which you have no way of measuring it in the previous. But with TTF, you can measure the pulsatility index, the diastolic volume, and also the reverse flow can be measured. So there's a much better technique to find out the quality of the graft, and your quality of coronary artery surgery can be measured. And if necessary, it can be revised. I think the revision rate was about 7.2%. This may be because of the kinking of the graft, or the distal end of the anastomosis has been kinked, or even posterior wall has been taken in another thing. So this can be detected on the table and can be revised at the same time. So it should be done, but I think in many people do not do it. I don't know. I'm not sure every case they do this. In Narayana, is it?
Yes, sir. In all
Hi, sir.
cases
Good
we are
morning,
doing,
sir.
sir.
Sundar here, sir.
Huh?
Good morning,
Is
sir.
it?
Sundar here, sir.
Yeah. Okay.
So we've
Yeah.
been doing it in Narayana for the past 2 years, sir, in
Yeah.
almost all cases.
Okay.
Almost all surgeons are using it now. And in fact, the final result post protamine, 10 minutes post protamine, is what we record, and we are giving it as a part of our operation note to the patient as well. So, post operatively, if the patient does come back with some kind of symptoms, when we do the angio, we can correlate to what was there intraoperatively.
That's very good, because previously, you have to depend on the post-operative in the ICU, the ECG changes, and the echo, where there's a regional wall motion abnormality to decide whether your graft is working well. This is very good. The other thing of the high frequency ultrasound, uh, it can be done intraoperatively too. Either epiotic scanning to find out the site of cannulation. Number 2, the site of cross clamping. Number 3, there you can put a side clamp if you are using a radial artery or saphenous graft, and also decide on the site of proximal anastomosis can be done by aortic ultrasound scanning. Similarly, previously we used to decide the site of distal anastomosis based only on your angiogram. You know where the block is, so you go distal to that. But there may be plaques posteriorly. So if you do the intraoperative pre-anastomosis, high frequency ultrasound, you can find out the exact place where you can do the distal anastomosis. So that's also great advantage. And also the other thing is, if you do perioperative pre-anastomosis ultrasound, can completely change your technique of surgery. That means if you find there's a plaque where your aortic cannulation is going to be or cross clamp or where the proximal anastomosis, you can change the whole technique from a on pump to an off pump, you know. Off pump, you don't need this manipulation of the aorta. So, perioperative pre-anastomosis ultrasound on the aorta should actually reduce the major adverse cardiac and cerebrovascular events. So I think routine use of PTFM and ultrasound, high frequency ultrasound, should improve the quality of the graft, also the long-term result. Don't know much about this, but practically, if you do that, it's a good idea so that you can, on the table itself, in the anastomosis, I think 7.2% or something, what I read in this case. That means this gives you an idea that the graft is about 7.2%. You can decide on the table and do it at the same time instead of transferring the patient to the ICU and they don't decide on the other parameters. So it's the safety and the quality of the graft will be better in that. That's my understanding of this.
Yes, sir.
Any other comments?
So the other comment is basically TTFM, especially for surgeons who are starting out. That has been extremely useful. Also, there is a learning curve in understanding the TTFM values as well, and not jump to conclusions immediately. So what happens is when we try to measure the flows of the TTFM graft, like say for example a venous graft in the OA position or in the PDA position, which is in an off pump beating heart surgery, the values change as the spasm probably reduces in the coronary because you've scored on the coronary spasm is there. Now all this changes once the map improves, once you let the heart down. And also one more important thing is it also allows the consultant to probably give more chances to the resident to do a distal anastomosis because now he is confident of checking how the graft is, even though like he will be in front and checking all the bites which the resident has taken. But I think in a training program as well, and for especially surgeons starting out, and now that minimally invasive is quite the rage, where we cannot feel the retrograde pulsation, where we cannot see that well, in minimally invasive and robotic, I think TTFM is a must.
Very good. That's why in the study of actually the surgeons included who are well versed with this technique, at least then 20 cases with 30 TFM and high frequency ultrasound. Only those surgeons' results are included in the study, not the learners. Good article.
Yes. Sir, like you mentioned, for example, how the graft flow when we do a venous graft, the flow, the toe of the anastomosis is something which we cannot assess that well. So that I've seen in my practice as well. Say, for example, I've done a venous graft. There's a very good retrograde flow which is coming. That means I have not compromised on the native flow of the coronary vessel. But I do the graft, I do the proximal, and then the pulsatility index is very high. And you can hear in the you can also have a audio uh, representation. You can hear the Doppler flow. So in such flows, you see that the systolic flow is there, but the diastolic flow is not there. Then you revise the graft. Once you revise the graft, then the pulsatility index comes down to normal. And this definitely has reduced the amount of sudden cardiac arrests due to graft dysfunction in the ICU in CBG patients. At least in the last 2 years, I think the residents would be able to attest to that fact more than me.
Yeah. I think the general research, if you don't detect on the table the problem of distal anastomosis, if it is detected only in the post-op ICU or later on, the research will be not as good as if it is done per-operatively. Because in the post-operative period, you have the EST segment or your echocardiography, that will be too late to revise and to take back to theater, and it can be done, but it will be, the results will be not as good as if you can revise it and
Correct.
rectify your mistake on the table.
Yes, sir. In two patients who had ST elevations, little bit of a low cardiac output, post-operatively, whose TTFM flows were very good. In one patient, we did a check angio where the grafts were flowing. And in another patient, I took the patient back for re-exploration and saw the grafts were doing well. But the other reasons for low cardiac output, so the TTFM values do correlate. In one patient of mine whom I had operated two grafts, Lima to LAD, vein to OM, that patient came back with angina 3 months later, uh, uh, class 2 angina. So I got this thing, ischemia scan done, which showed a large area of LAD territory ischemia. So we got the angio done. In the angio, the Lima LAD is flowing well, but there was a constriction at the just prior to the anastomosis. Um uh, just probably a centimeter or two prior to the anastomosis. So even if the graft was flowing, so the TTFM definitely will show you the patency of the anastomosis. But probably, yeah, like as the study has mentioned, the long-term patency will depend on a lot of factors. Probably a clip which was pinching too tight on the Lima. These things will not probably be shown by TTFM, and there probably a conduit assessment by a high frequency ultrasound would be a greater option to get better results. The only problem is right now we are using the TTFM probe, which is a Japanese probe, which is pretty cheap. Actually, the one probe is 1 lakh rupees, but we are able to reuse it for 40-50 cases after ETOing it, sterilizing it. So by the time it is in the 45th case, it usually doesn't work. And it doesn't give that much of values as the Medistem, which has been used in this study, which is actually all more than a 1 crore 40 lakhs machine. So, but then the machine which we using right now, Japanese, it's quite sensitive. It might not be extremely specific, but it's very sensitive. So it can say yes flow, no flow, poor flow, good flow. So almost like that. It does give values of pulsatility index, then mean graph flow and peak graph flow. But that is quite good, sir. Which is so we are planning to try to get it refurbished and the older probes and trying to get it made in India itself by giving it to a local ultrasound manufacturer here
It's good.
to reduce the cost.
Okay, very good. Thank you very much.
Thank you, sir. Thank you.
Thank
Thank you, sir. Thank you, sir.
Thank